Hello, everyone, and welcome. My name is Maureen Aslan. This is Dying with Dignity's presentation in honor of our 40th year, and we'll be telling you more about the content of the broadcast. I want to just let you know that it takes a couple of minutes for everybody to get on the webinar itself, so we'll allow that to happen. We're really excited to have everybody join us today. I think we'll have over 500 participants by the time we get everybody loaded on the system here. We will be doing presentations of the three panel speakers, and then we'll move on to a question and answer session. The question and answer session is one where you will be able to type in your questions. You'll notice when the screen is open at the bottom, there is a black bar with Q and A as one of the icons in the bar. You can click on that and enter the question that you have. You can type it in. If you're not able to type it in or not comfortable doing that, you can raise your hand and then let us know. I will keep an eye on the raised hands, and we'll let people come on mic briefly to ask their questions. Now, when you're asking a question, we ask that you suggest who you might want to have answer that question. That'll facilitate the question period going a little bit faster. So without further ado, I will ask Susan Desjardins to take over as the moderator.
Well, hello again to everyone, and thank you so much for joining us for this panel discussion. We have hosted this type of discussion before in person with great success, but this is going to be a new adventure for us, having so many participants and doing this through Zoom. So I'd like to take a moment to introduce our three panelists. We have Daphne Gilbert, who is an associate professor in the Faculty of Law and Vice Dean of Governance at the University of Ottawa. Her focus has been on constitutional law, the Charter of Rights and Freedoms, and the impact of conscientious objection. And I understand she's going to be releasing an article shortly on that topic. Since MAID legislation came into effect, Daphne's been a very dedicated and active independent witness with Dying with Dignity in Ottawa, and has willingly shared her knowledge and expertise in a number of MAID presentations and panel discussions here. She's also published research and opinion papers on MAID legislation, often in conjunction with Professor Jocelyn Daphne. Louise Linney, Dr. Louise Linney is a wonderful friend of our chapter in Ottawa, and in fact attended our very first advanced care planning presentation about 5 years ago, when she was still practicing family medicine. She also subsequently attended an early MAID presentation, and as MAID became legal in Canada, saw a need in the community. When she left her longtime family practice, she offered her expertise in the community as a physician assessor, and subsequently to ensure a good death for as many people as possible, as a physician willing to alleviate the intolerable suffering of individuals who had received approval for MAID. She's also continued to be involved with our Ottawa chapter, either calling upon our independent witnesses or, again, as Daphne has, sharing her knowledge and expertise. And Maury Prevost. Maury is a Dying with Dignity supporter who's been working very closely with our advanced care planning team as we, in that case as well, migrate our advanced care planning workshop to Zoom. Maury has personally experienced the MAID journey with his wife, Marilyn. He's going to share his story through which he explains the importance of having access to MAID and why Audrey's amendment proposed in Bill C7, which would allow a waiver of final consent, could have been critical to Marilyn's access to MAID. So please welcome our three panelists, and I'll turn it back to Maureen to lead off with our first panelist. Uh-oh, have we lost Maureen?
Yeah, thank you. I'm here. I'm just sharing my screen. There is the slide.
Okay, so do you want me to just get started?
Please do.
Yep.
Sorry, we've got the technology up and the slides ready to go, so please go ahead.
Okay, so if you go to the next slide. It's actually, well, I would say there's my contact information. So these slides will be available after the presentation, and I'm more than happy to have people email me if there's questions or resources that they want to get, or more information on some of the links I've got in the presentation. So my email is at the beginning there. You can go to the next slide. Thank you very much, Susan and Maureen and Dying with Dignity. I'm always happy to be part of these kinds of events. And thank you to everyone for showing up today. I have to tell you, I would normally be really freaked out about talking to this many people, but it feels very normal to be talking into my computer screen. I've been Zooming like crazy for the past few weeks with my university colleagues. So this feels really normal, and I'm going to pretend that I don't know how many of you are out there. My object today is to give you a brief overview of the state of the law around MAID right now, what's happening now, what might and should be happening by July of this year, and then going forward into the future with some challenges ahead. So you can go actually 2 slides ahead, Maureen. So right now, we are still operating under the original MAID regime that was set out in Bill C-14. Just in terms of the immediate situation, and I'm sure Louise, Dr. Linney will be talking more about this, but COVID has resulted in some temporary pauses in MAID programs in some regions, in part because hospital resources are being directed towards more acute and predicted acute needs, and in part because the transfer between institutions is difficult. It's also very challenging, I think, for people to arrange MAID because of the very limited number of visitors that are allowed in hospitals and in long-term care homes, and so bringing your family together for MAID is very challenging. But my understanding is that a lot of programs have resumed, and so, you know, those challenges are being worked through. You can go on to the next slide. I don't know how many of you can remember back to February 2020. It feels like forever ago to me, like a whole different lifetime. But back then, MAID was already in flux even before COVID-19. Time seems to have stood still since then, but we are at a point of big changes, although I haven't heard much lately about what the government is doing. I think they're a little preoccupied. Many of you out there, because you're supporters, have probably participated in the consultation process that happened in January and February when the government had an online survey about MAID. I think it's interesting that the response by the public to that consultation process involved more people than consultations around cannabis, the food guide, and pharmacare combined, which just shows you the incredible interest that MAID generates and the way that people have a very invested stake in what is happening. Okay, you can go on, Maureen. As a result of those consultations, and in part as a result of a decision in Quebec, the Truchon case, the Minister of Justice introduced Bill C-7 on February 24th, 2020 to amend the criminal code with respect to MAID. It's the first set of amendments we've seen since the original legislation was passed. Okay, you can move on. It's very weird having someone else control your slides. So the Truchon case was a challenge to the requirement that your natural death had to be reasonably foreseeable for you to be eligible for MAID. So I'm just on this slide, and I'll give you a second to take a look at it. This is just a reminder of what the criteria are right now for MAID. And then you can go to the next slide, Maureen. One of the main criteria is that you suffer from a grievous and irremediable medical condition. And these are the 4 parts to that definition. It's the last one, D, that natural death has become reasonably foreseeable, that was found to be problematic in the Truchon case. Justice Baudouin found that to be a violation of the Charter of Rights and Freedoms. The case was also brought under Quebec's own end-of-life legislation, and she also found it violated the provision that you had to be at the end of life to access MAID, that violated the charter as well. So both of those aspects of the eligibility criteria were struck down in the Truchon case. She gave the government 6 months to fix the law. She assumed they would want to do something and not just see that criteria disappear without adding any other safeguards. So she gave them 6 months. The government asked for an extension for an additional 4 months, and that was granted. So now the reasonably foreseeable requirement will expire on July 11th, 2020. And that is what Bill C7 is meant to respond to. So that's where we stand now. What will happen by July? The amendments that are proposed by Bill C7 respond to some of the most pressing issues that people had concerns about over the past few years. The main change is the response to the Truchon decision. That's the removal of the eligibility requirement that death has to be reasonably foreseeable. There's now a separate set of procedural safeguards for those whose death is not foreseeable. But in addition to that response to the Truchon case, other changes were made in the legislation, and we'll walk through some of those now. So you can go to the next slide. The proposed legislation offers 2 pathways now for MAID, a pathway where death is reasonably foreseeable and a pathway where it is not. And so there is differences between those 2 pathways in terms of criteria. One of the most significant differences, and I saw that we already had a question about this, is when your death is reasonably foreseeable, you have to have 2 independent assessors make that decision with you, and both of them have to agree that you meet the eligibility criteria. If your death is not foreseeable, Bill C7 now provides that one of those assessments has to be done by somebody who has expertise in the condition causing the suffering, which is not required if your death is foreseeable. And maybe Louise will speak a little bit to that in her remarks. The legislation removes the 10-day waiting period for those whose death is foreseeable. You no longer have to wait 10 days between your request and MAID, but it institutes a new 90-day assessment period for those whose death is not foreseeable. So if you are going down that pathway, the time from the first assessment to MAID should encompass at least 90 days unless there's an imminent loss of capacity predicted, and then there's going to be mechanisms to subvert that 90 days. In addition, in terms of safeguards for people whose death is not reasonably foreseeable, there's new requirements around counseling and information provision. And in particular, both of the assessors, both physicians or nurse practitioners, have to discuss with the person ways that the suffering could be alleviated, and they must agree that the person has given serious consideration to those alternatives. So there will be more of a burden on the assessors now in terms of the conversations that they're going to have with people who are going down that pathway for MAID. You can go to the next slide. Because the requirement for a natural death being reasonably foreseeable was struck down, and the concern, therefore, that it would open the door to the potential for people with mental illness as their only underlying condition that would qualify for MAID, that without having the death foreseeable aspect for qualification, that would open the door to people with mental illness. Bill C7 specifically states that mental illness is not an illness for the purposes of a definition of a grievous or irremediable condition. It's not alone enough to qualify for MAID. I think the Minister of Justice felt the clarification was necessary in the short term to respond to this door opening from the Truchon case. But this is one area where the government has already had additional study, and I'm going to talk about that in a minute. So I think this is a short-term solution in order to give people more time to have thoughtful conversations about how to accommodate this population in the MAID regime. So I think there'll be a lot more happening in that area. Okay, can go on. One change that impacted me directly was the proposed changes to independent witnesses. Only one will now be required instead of two. And so as a volunteer independent witness, I might see my schedule get a little freer now. And also the independent witnesses can be people who are involved in providing healthcare or personal care to the applicant. As long as the witness is a professional caregiver and they're being paid to provide that care, that's where the independence would come from. But it does open the door to a lot more people who could act as witnesses, which I think is a good thing if we're going to keep the witness requirement. And then you can go on. And then the last amendment I want to talk about is what I think of as the most profound one, and that is Audrey's amendment. Many of you will be familiar with the story and advocacy of Audrey Parker, a woman in Nova Scotia who had stage 4 breast cancer and wanted to live through one more Christmas, her favorite time of year, but was afraid she would lose capacity before she could access MAID. And the law requires you to be able to give consent at the moment that MAID is being provided. You have to have capacity to give consent when you're about to receive MAID. So she ended up dying much earlier than she wanted to in November of 2018, but she was a powerful advocate for a change in the law, Audrey's amendment. And that work has come through in Bill C7. It outlines requirements where you can waive the need to give consent at the very time that MAID is provided. Maureen, you could go to the next slide. This is only available where death is reasonably foreseeable. And in that case, there's 2 slides here. The first issue is the things you have to do before you lose capacity, and that is that you have to be eligible for MAID. So you have to fulfill all the criteria. You have to enter into an agreement in writing with your physician and specify the date on which you want MAID. That physician has to tell you there's a possibility you will lose capacity, and you have to agree in the arrangement that you consent to MAID on or before the day specified if you lose capacity. So it waives that requirement that you be roused at the moment of MAID to give consent. And then you can go to the next slide. If you lose capacity, MAID cannot be performed if you demonstrate any refusal by words, sounds, or gestures, although the proposed legislation does leave room for these involuntary words or gestures that won't count as a refusal. But if you refuse, MAID cannot be provided. And you also have to have MAID in accordance with the terms of your arrangement with your provider. And again, maybe Louise will be talking a little bit more about that too. But this is a significant change to the law, I think, and one that we can credit entirely to Audrey Parker's advocacy in getting the ball rolling on this one. And so I'm really happy that this is part of the Bill C7. Okay, so I'm imagining the government is pretty preoccupied at the moment, but they haven't got many choices in terms of putting this on the agenda. First, because on July 11th, 2020, the Truchon decision will kick in if they haven't passed legislation. So Bill C7 will have to be passed before then. I can't imagine they'll get any more extensions in time. But also there is a statutory review that is mandated by the legislation, the original Bill C14, and it has to happen after 5 years of the legislation, and that will be in June 2020. So as of June 2020, the government is going to have to engage in some kind of statutory review of MAID and how it's been rolled out and some of the challenges that remain. The legislation, the original Bill C14, mandated that the Minister of Justice have an independent review of 3 specific issues, 3 categories of people or populations that were excluded from the initial MAID legislation. And that is requests by mature minors for MAID, advance requests, and requests where mental illness is the sole underlying medical condition. Those working groups published their reports in December of 2018, and I recommend, if you haven't looked at them, that you do. They're very accessible. The full report is very long, but there's really good executive summaries of each of the groups, and they're very interesting reading. I just want to briefly touch on some of the main questions in each of those three issues that are going to be part, I think, of the government's review process. So the first set of questions are ones that were for all working groups to consider, and that is to look at the individual implications of MAID for these three areas on families, on the people themselves, and on healthcare providers. We recognize, for example, in the case of mature minors, that the impact on healthcare providers could be very relevant to how we roll that out and how we, what kind of conversations we have about MAID for mature minors, for example. What are the impacts on society of opening MAID up to these three different areas or populations? What risks and special safeguards might be needed, and what don't we know? What are the gaps in both international and domestic research on these three different areas that we need to look at and consider before we move forward? With respect to mature minors, just a reminder, right? A person right now has to be 18 years old to be eligible for MAID. So the specific questions that that group was asked to tackle were what the impact of chronological age is on the legal capacity to request and consent to MAID. So, you know, at what point along one's growth as an adolescent do you reach the point where you can start to take part in your medical decision making and have some autonomy and authority over it. And then secondly, what the unique considerations are with respect to minors. So the differences between a minor and an adult in MAID, for example, or the difference between MAID as a healthcare decision and other healthcare decisions that we might allow teenagers to make for themselves. So the group was focused on those kinds of issues. You can go to the next slide. So I should say none of these groups made formal recommendations to the government about what to do. That was not as part of their mandate. They were mandated to study the question, to gather evidence and research, and to present some analysis, but they don't make recommendations. But they did say with respect to minors that they don't think that there should be a chronological age cutoff alone, that we should be expanding the conversation to include teenagers who have reached a point of being able to give informed consent and participate in those conversations. The question that remains for this group and for all of us is the extent to which minors make free and informed decisions that are not in any way attributable to their family or community pressure. I think that's going to be an issue. And we already allow mature minors to make decisions, so we have to think about whether MAID will be part of it. You can go to the next slide. These are the safeguards that the group talked about that would be necessary for mature minors. You can see parental consent is one issue in there. And then you can go to the next one. So mental illness as the sole underlying condition, Bill C7 now makes MAID inaccessible to this population. The specific questions that this group was looking at are the relationship between a mental illness and capacity to request and consent to MAID, and when and how mental illness plays into informed consent. I would say this is the population around which there is the least consensus about what to do and how to open MAID up. I think there's considerable conflict within the mental health practitioner community about how to safely open up MAID to this community. So you can go forward a couple of slides, actually, I think, Maureen. And one of the issues is the safeguards that might be put in place: psychiatric consultation, judicial approval, mandatory review of cases. This is, I think, an area that's going to occupy a lot of conversation. And then finally, with respect to advance requests, if you go to the next slide, you can see I have a definition here of what an advance request is. It's a request that is made before you lose capacity that is intended to be carried out after you lose capacity. We have to distinguish that from advance directives, which we currently allow for healthcare, which usually has a designated person who can make decisions for you, or specifies certain treatments or well, mainly treatments that you either accept or would not accept if a certain set of conditions were met. So if you go to the next slide, the issue for advance requests is how they will be different from advance directives for other healthcare issues. And then the unique considerations of the timing of your advance request. Is it before diagnosis? Is it after diagnosis but before suffering? And then the third one, which the group addressed, has now been taken care of by Bill C7, which is the waiver of final consent. So it's really going to be the issue of advance requests before a diagnosis or after diagnosis, but before the suffering has reached the intolerable level. You can go to the next slide. And this is by way of conclusion to say most Canadians are in favor of advance requests. There's less consensus on expanding MAID to include mature minors and mental illness as the sole underlying condition. And there are very prominent voices like Jane Philpott and Jody Wilson-Raybould who are advocating caution. This particular quote was from an editorial to do with Bill C7 and their desire to not see the removal of the criteria of reasonable, of natural death reasonably foreseeable. So there's a lot of conversations still to be had. And then the last slide, this is just the legislation. I just reprinted the section that says that we're due for a statutory review as of June 2020. It will involve both MAID and palliative care, and given the level of interest and strong voices on all sides, I think it's going to be interesting times ahead for MAID.
Great, thank you so much. We will go to Louise and her slide presentation, and I'll just make the changeover on the slides. And we'll make it large enough so everybody can see it. And Louise, please.
Great, thank you very much. I'd like to thank Dying with Dignity for inviting me to speak today to this topic. And I've been asked to address 3 issues today. One is who has benefited from the legalization of MAID in Canada? The next is when does MAID not benefit a person? And finally, how will the proposed amendments to our current MAID law impact Canadians? So the question can be asked, who has benefited by the legalization of MAID? Approximately 3% of deaths in Ontario are a result of an assisted death. So who is it that benefits? Next slide, please. It's certainly healthy people. 86% of Canadians support MAID. And when you speak to somebody about assisted death, they often comment on how happy they are that they live in a country where they know that an assisted death is available to themselves or to a loved one if it were ever required. Next slide, please. Family members and friends of people who have asked for MAID benefit because it brings them great relief to know that their loved one can end the suffering if that's what they're wishing with an assisted death. And I think in particular of a longtime nurse from England who came over to Ottawa to be with her sister for her last month of life here. And she was very impressed with the home palliative care that her sister had received. And after watching her sister pass with her MAID provision, she was very comforted with just how peaceful a death her sister had had with the MAID provision. And she took me aside after the provision and said that it was going to be her purpose when she went back to London, England, to fight for the legalization of an assisted death in England. that was how much of an impact her sister's MAID journey had on her. Next slide, please. Who else benefits? Well, people who are living with a serious illness. And the emphasis here is on people who are living with their illness. I've met with many, many people who have serious life-threatening illnesses, and they want to be seen as vibrant members of the community who still have hope and purpose, who still have vital relationships, and they want to be living in spite of their illness. And I think this comic strip sums it up nicely. Charlie Brown is saying, "Someday we will all die, Snoopy." And Snoopy responds, "True, but on all the other days, we will not." Next slide, please. Well, there we go. One of the patients that I think of is a gentleman I'll call Bill, who truly took on that attitude of living with his serious illness. He was an avid outdoorsman, a canoeist, and he had been diagnosed with pancreatic cancer. And he asked for his MAID assessment very early in the course of his illness. He said to me, "I need to be in control of my destiny." Once he had had his assessment, he wasn't eligible at that time because he was so early in the course of his illness, but it gave him comfort to know that eventually, if it was required, he would be eligible for MAID. And it was with this knowledge of his eligibility that he went ahead and he went through multiple types of traditional treatment for pancreatic cancer, and he even went out of country for experimental treatment for his cancer. And he said to me, "What's giving me the courage to fight on and go through difficult treatments is the knowledge that if all becomes too much, I do have MAID to fall back on." And so the idea that he knew about his death is what let him live fully during this time of fighting his illness. Next slide, please. There's another patient of mine that I think of who I'll call Jack, and he was an engineer and he had recurrent cancer. And when he asked for his MAID assessment, he had said, "I want this assessment and then I want to make sure I can have my provision in a week or two afterwards. I want it as soon as possible." We went through the assessment procedure, and I gave him my phone number so he could call and let me know when it was that he wanted to go ahead with his MAID provision. And he called me that evening, actually, and said, "I've been thinking about this, and now that I know that I can give you a call and I can have my MAID provision within a matter of a few days, I want to actually spend a bit more time. I want to spend my days creating memories for my loved ones and my friends. And I'll call you when I'm ready." And one of the things he did was he bought a telescope. And he and his daughter every night would look through that telescope and look at the stars and the planets, discuss what they found, discuss their philosophies of life. His daughter shared with him her hopes and her dreams for the future. And this was what he spent his time doing, creating memories and actually living during this time. He and I would talk every couple of weeks to see how he was doing. And it was 3 months after his assessment that he went on to ask if he could please have his provision at that time. And it went very peacefully. Next slide, please. Patients who are dying with their illness. So when there's no further hope of a curative treatment, there's still the hope that they will have things to contribute in life, that they can work on their relationships, they can bring closure to unfinished business, and they still have a purpose, and that is to finish their life how they wish to finish it. Next slide, please. A patient that I think of in this way is a woman that I'll call Helen, who was in her 90s, and she had metastatic cancer. And she had gone through all the treatments that were available. She was able to have palliative care to keep her comfortable, but there was no further treatment to prolong her life that was available. And she accepted that she was dying, and what she wanted to do with the months that were left to her was she wanted to create her own celebration of life. She wanted this to be on her birthday and wanted it to be with all of her friends. And so she organized a celebration of life for her birthday with her choice of finger foods and light refreshments, the prayers and the readings that she wanted, and which family and friends she wanted to be present. I even received a written invitation to the provision that told me there'd be light refreshments and finger foods offered. It was a beautiful day. She celebrated her birthday with her friends and her minister present, and we finished it with her MAID provision, with all present and holding hands. Next slide, please. Finally, those patients who are actively dying benefit from assisted death. So these would be patients who have a matter of days to weeks left to live. And MAID is of great assistance to those who wish to die in that manner. Next slide, please. One example that I think of is a woman who I'll call Barb, who was a farmer, and she had widely metastatic cancer. Unfortunately, at the end of her life, with the metastatic disease, she developed a very severe complex pain syndrome. She was seen by multiple specialists who were not able to solve her pain problem. She was under the care of an excellent palliative care specialist who also could not solve the problem. And I must say, the vast majority of pain that occurs with serious illness and with dying, the vast majority can be successfully treated with palliative care. But in Barb's case, they just couldn't find the right treatment regimen for her. She was seen, assessed, and she was able to have a very peaceful provision within a matter of days. Next slide, please. I also think of Corinne. Now, Corinne is a woman, that's not her name, but she's a woman who's a very strong matriarch of a large family. She had end-stage COPD, and she also had mild to moderate dementia. And when she had asked for a MAID assessment a year earlier, the family doctor had said that having mild to moderate dementia would disqualify her, and she wasn't given an assessment. Her granddaughter was quite internet savvy and did some research and learned that, in fact, she could possibly have a MAID provision. And so she did ask for an assessment again, and she was assessed, and she was found eligible. And for Corinne, her family was so vitally important. On the day of her provision, she was on a king-size bed, and she had 4 generations of family present. And everybody who could fit on that king-size bed was with her, lying there and holding her. And those family members who couldn't lie on the bed were standing around the bed. Everybody was holding arms, touching hands. And Corinne died literally in the arms and the embrace of her family. Next slide, please. Next slide, Maureen, please. So I've also been asked to speak to when is it possible that a patient does not benefit from MAID. Next slide, please, slide 14. I think to answer that question, it's important to remember that a good death is the goal. And so for a good death, that's by definition what it is that the patient is asking for. And each patient, depending on their health problems, their situation, will come up with their own idea of what is a good death for them. And medical assistance in dying is a tool that can be used by a doctor to help a patient obtain their goal at the end of life. MAID is never the goal. If I hear a patient say, I want MAID, what I hear is, I want a good death, and I think that MAID is what will give me that good death. What's really important, in addition to having MAID available, is having palliative care accessible. It's palliative care, whether offered by a palliative care specialist or offered by a family doctor with expertise in palliative care, that keeps symptoms under control for the patient. It's that palliative care that keeps people comfortable while they await a MAID provision if that's what they want. But the majority of people end up having palliative care as the comfort right through to the end of life, and they die peacefully with the good death that they want. Slide 16, please. I've been asked a number of questions by several people about what happens with COVID infections. Is it possible to have MAID if I end up with a serious COVID infection? And I think COVID is a good example of where MAID would not fit in to be the best option for somebody wishing a good death. It's really important to remember that the vast majority of people, even those of advanced age or with other illnesses, the vast majority of people with a COVID infection will recover. And so if you're looking for possible MAID assessment, it's not going to become clear that you are eligible for MAID until you're at the end of that illness, when it's very severe. Basically, when the doctors are saying it's time to consider, do you want to have be put on a ventilator, or should we keep you comfortable? And most likely at that point, with your low oxygen level and the medication you're on, you most likely would not have capacity to consent, and you would not be eligible to go through the process. But even if you did have capacity, at that point, everybody realizes that it takes time to go through the MAID assessment process, find the two doctors, get things organized. And if you're lying in a hospital bed so short of breath that you need a ventilator or you need to be kept comfortable, you're going to want the very fastest solution. And palliative sedation is medication that it can be given very, very quickly by your attending doctor that would put you into a coma and make sure that you're feeling no pain and no awareness of your shortness of breath. This will be a much faster answer than a medically assisted death in the face of a very serious COVID infection. So this would be one example where medical assistance in dying would not be a manner that would give most people the good death that they were looking for. Next slide, please. So I was also asked how might the proposed amendments to the MAID legislation impact Canadians, and Daphne's done an amazing job to go through all the different amendments in Bill C7. I'm just going to touch on a few of them that I would see from the bedside, what the effect would be. Next slide, please. Very happy that the witness requirements have been changed. Big shout out, big thank you to the Dying with Dignity witnesses. Many, many times my patients would not have been able to proceed with their MAID request because they simply didn't have people in their lives who could act as witnesses to their request. So this is going to go a long way to make it easier for people, and certainly the Dying with Dignity witness program has been tremendous. So thank you very much. Next slide, please. Daphne spoke about Audrey's amendment, and this is Audrey Parker, the woman behind the amendment. Next slide, please. Many of my patients would have benefited from having access to Audrey's amendment, and I'm pleased that that has gone through. There's a patient who I'll call Sylvie, and this is not her photo, but it's representative of what happened with Sylvie. She had widely metastatic cancer, including brain metastases, and she was at very high risk of losing her capacity. She was also expecting her very first grandchild in about 6 weeks' time. And so she was faced with a very difficult decision of going through with assisted death now, when she knew she had capacity and could have it, or waiting to meet her first grandchild and risk losing her capacity and thereby not be allowed to have MAID. Sylvie made the heart-wrenching choice to wait to see the birth of her grandchild, and she realized that if she did lose capacity, that was going to be the price that she was willing to pay in order to hold that grandchild. So that's the choice she made, wait. And fortunately, her daughter did give birth in 4 weeks instead of 6 weeks. And her daughter bundled up her newborn and drove halfway across Canada to come to Ottawa to place that newborn baby in her mom's arms. And so Sylvie was able to hold her baby, meet her new grandchild, and 3 days later, she did have capacity and she did undergo her MAID provision with her daughter and her newborn grandchild at her bedside. Next slide, please. So Daphne spoke a lot about Bill C7, and Bill C7 places people in 2 tidy categories. There's people with a reasonably foreseeable death, and there's people without a reasonably foreseeable death. And unfortunately, medicine is not that tidy. There's a gray area between these 2 categories that have patients who don't easily fall into one category or the other. And Kay Carter, and this is a picture of Kay Carter here. Kay Carter is a good example of a patient in this gray area. She was 89 years old with spinal stenosis and no other significant health problems. It was her Supreme Court challenge, the Carter decision, that led to the legislation that we have allowing MAID in Canada now. Clinicians still cannot agree if Kay Carter and all the many other patients who are like her, whether they have a reasonably foreseeable death or not. So does it matter clinically which category a patient is placed in for eligibility? Absolutely yes. And Daphne went through this in her presentation, but I'd like to show a slide to take you through the practicality for somebody like Kay Carter. Next slide, please. So if you look on the left-hand side of this chart, this is what would happen if Kay Carter was found eligible by 2 clinicians who agreed that her death was reasonably foreseeable. There'd be no mandatory reflection period. She would need 2 clinicians to assess her eligibility, and there's no requirement for either of the clinicians to have any particular expertise in a certain area. And she would have the option to waive the capacity to consent at the time of MAID. So she would have the option of having Audrey's amendment if she wanted. On the other hand, take a look at the right-hand side. The right-hand side, you can see that if her assessors found that she was not eligible, not foreseeable death, she would have a 3-month wait period. Of the 2 clinicians, one would have to have expertise in the area of her suffering. In this case, it was spinal stenosis. And spinal stenosis has neurosurgeons, orthopedic surgeons, or physiatrists. And there's no assessors or providers in that area who would, who are currently assessors or providers. And so it would be a stumbling block to find assessors or providers with expertise. The other thing is that she would not have the option to have Audrey's amendment. Next slide, please. I would just like to leave you with this image and these words from Samuel Coleridge. How well he fell asleep, like some proud river widening toward the sea, calmly and grandly, silently and deep, life joined eternity. Thank you very much.
Thank you, Louise. Next speaker we have is Maury. Maury, please go ahead.
Hello, everyone. My wife, Maury Prevost, died with medical aid at home on December 2nd, 2019. As I said in an email message that I sent that evening to over 160 family and friends, quote, during her final weeks, Marilyn was pain-free, comfortable, and enjoyed the best quality of life possible under the circumstances. She had a good death, just as she had a very good life, unquote. In this presentation, I want to explain why it was a good death, including the role of MAID. from the point of view of being her spouse of 44 years and primary caregiver as her health declined. I will also share some thoughts on how this relates to the anticipated legislative review of MAID and palliative care. I married Marilyn in the summer of 1975. 4 years later, she received her lifetime dose of radiation therapy to treat an endometrial sarcoma, cancer of the uterus. This treatment had serious side effects, some of which were not apparent until 30 or more years later, but it gave her 40 more years of life, a trade-off that was unquestionably a good one. However, the treatment did not prevent the cancer from recurring, as a tumor in the lung in 2006 and a tumor in the left shoulder blade area in 2008. Both of these tumors were surgically removed. When Marilyn died, she had a slowly growing tumor in her lower abdomen, likely a third recurrence of the original cancer. This was one of two medical time bombs, as I characterize them, that Marilyn was living with and that we knew about during the last years of her life. The other time bomb was declining kidney function. We had known about this at least since early 2017, and we also knew that in-center hemodialysis was the only treatment option available in her case. In June of 2017, we had attended a dialysis information session at the Riverside campus of the Ottawa Hospital, where we received some publications that ended up being very helpful for one of the key decisions during Marilyn's final illness. What turned out to be Marilyn's last meeting with her multi-care kidney team took place on July 22nd, 2019. At that time, her kidney function was estimated at 11%, very close to the 10% threshold for starting dialysis. Marilyn's final illness began at the end of the Thanksgiving long weekend in October 2019, when she developed a bad cough. We visited our family doctor on the Thursday morning. He diagnosed an upper respiratory infection, likely viral. He also told us to come back on Monday if her condition had not improved. It did not improve, and we visited our family doctor again on Monday morning, October 21st. This time, the doctor was very concerned by her symptoms and advised us to go straight to the emergency department, which we did. By the end of the afternoon, she was admitted to hospital with the diagnosis of having pneumonia in both lungs and, more significantly, a kidney function of only 5%. The latter diagnosis led to a discussion of dialysis. Marilyn initially agreed to start dialysis, but by the time of my evening visit to the hospital on October 24th, she was having second thoughts. Her nurse had called before I left home to tell me this, so I came prepared with the Living with Kidney Failure book that we had received in 2017. This enabled Marilyn and I to have a long discussion about the options and factors to consider. We agreed to defer the final decision until meeting the kidney specialist the following morning. On Friday, October 25th, in consultation with the staff nephrologist at the hospital, Marilyn made the decision, fully supported by me, to pursue what the book calls non-dialysis supportive care instead of dialysis. This decision in effect meant going into palliative care, knowing that she had, at the very best, a few months to live. This immediately shifted the focus into making her as comfortable as possible and preparing to move her as soon as possible into home-based palliative care, her first choice. This took 10 very busy days, working with a large cast of characters to organize and make happen. Marilyn came home Tuesday morning, November 5th. She had said when we bought our condominium apartment in the fall of 2003 that she hoped that she would only leave permanently in a pine box, to quote an old saying. Well, it wasn't a pine box, but otherwise she got her wish, which was part of what made it a good death. We first met the palliative care doctor, who turned out to be an important ally, the day after Marilyn came home from hospital. MAID was part of this initial discussion at our request. I don't recall when or how much we had discussed this option during the previous 2 weeks. But Marilyn had told one of her first cousins by phone in my presence on October 30th that, to quote my notes, "I'd like to slip away as soon as possible," end quote. And the possibility of MAID had also been discussed with Marilyn's daughter, my stepdaughter, who had arrived from her new home in BC while Marilyn was still in hospital. Marilyn and I had talked enough about end-of-life considerations prior to her final illness to know that considering MAID was consistent with our shared values. I believe that one of the things that influenced Marilyn's view on this subject is what happened to one of her uncles in the 1980s. He had a massive stroke, but survived as a result of medical interventions that one of his children insisted upon. His resulting quality of life was so poor that I recall him being in tears most of the time when we would visit him. Bear with me as I go into some detail about Marilyn's final few weeks. I do so to explain that we were able to arrange MAID for her about as quickly as is possible, and that we were well supported by the system and the healthcare professionals in doing so. And I'll add that I think it helped that it was all home-based because we weren't having to schedule around hospital resources. On November 12th, early in the day, Marilyn and I had a discussion about end-of-life arrangements, which included confirmation that she wished to pursue MAID, but would prefer not to ask friends or neighbors to witness her signing the clinician aid a patient request for MAID form. I called the palliative care doctor who advised me to contact the Dying with Dignity Ottawa chapter for volunteer witnesses. I did some online research and readily found the name and phone number of the coordinator. I left her a voice message and she called back in less than 1 hour. And within a few hours of our initial contact, still on November 12th, she had identified 2 volunteer witnesses to come on Monday, November 18th. The 2 witnesses came as scheduled and did their work with compassion and efficiency. The palliative care doctor had arranged to visit at the same time so that she could take the form and expedite it into the system. 1 week later, on November 25th, I had a phone call from an employee at the Ottawa hospital who coordinates MAID in our region. She told me that she would proceed to schedule the 2 physician assessments required. The following afternoon, I heard back from the first physician, and the morning after that, the coordinator called me to schedule the second assessment on December 3rd. The first MAID assessment took place on Thursday, November 28th. We knew it would take on the order of 2 hours, and it did, somewhat more in fact. This was an endurance test for Marilyn, who was fighting fatigue and at times struggling to put her thoughts into words. But the end result was positive. However, the assessor was concerned that MAID needed to happen by December 6th to ensure that Marilyn would still be able to give the required final consent. This was because of the clear progression of her kidney failure. I'll talk near the end of my presentation about the proposed Audrey's amendment, which would have helped in this situation. It was at this point that things went into overdrive in a very helpful way. The first assessor said she would ask the second one to come earlier and that she would try to arrange for MAID to happen before December 6th. So on Friday, November 29th, the following happened, and there are actually 4 things that happened. Firstly, having confirmed at the beginning of the day that Marilyn wished to pursue MAID as soon as possible, because she had no wish to prolong things for herself or her loved ones, we had an important discussion with her sister and brother-in-law about what was probably going to happen and when. They said they wanted some time to think about it, but would probably choose to be present for the MAID procedure. The same day, secondly, the second assessor called to say she would come the morning of Sunday, December 1st, 2 days earlier than originally planned, and taking time out of a day that she would otherwise be spending at home with her family. The first assessor, the physician who assisted Marilyn's death, tentatively scheduled the procedure for Monday afternoon, December 2nd. And the 4th thing that happened on Friday, November 29th, was that the palliative care doctor and the regular weekday nurse from Care4 made their final visits and said their goodbyes. The doctor, having just heard from the MAID practitioner by phone, reduced Marilyn's pain medications with the objective of helping to ensure that Marilyn would be alert when she needed to give final consent. This also took into account that less pain medication is needed as the kidney failure progresses. And the remaining days of Marilyn's life were good on both counts. That is, being alert most of the time and pain-free all of the time. The second physician assessment on the Sunday morning went very well and was completed in less than 1 hour. Now all of the requirements had been met for a medically assisted death to take place the following afternoon. The last 30 hours of Marilyn's life were full of goodbyes with family and friends, in person, by phone, by email, and by text message. These were in addition to other goodbyes that had taken place during the previous week or two. Marilyn was in good spirits. On Monday, December 2nd, her death was pronounced just before 5 p.m. She died with me at her side and her sister, brother-in-law, and their daughter in the room, along with the doctor and nurse. When the doctor asked Marilyn what was going to happen, she replied very clearly and without hesitation, "You're going to give me an injection and I'm going to die." And when the doctor then asked, "Is this still what you want?" the reply was an equally firm yes. Her death was quick and peaceful. She was ready to go. She had her hands on her chest with one of mine on top. She appeared to stop breathing within a minute or so of the first injection. The doctor and nurse were very professional and compassionate. I was also very grateful to have close family members there to support me as well as Marilyn. Without MAID, Marilyn likely would have slipped into a coma naturally and died peacefully from kidney failure within a couple of weeks or less. This is what I understand from the medical professionals. Her palliative care physician referred to this as a good plan B. I have reflected on why MAID was an even better option, and my conclusion is that her medically assisted death fulfilled her wish to not prolong her dying and has allowed Marilyn to be Marilyn right to the very end. By this I mean such things as enjoying her interactions with people, smiling, being able to have meaningful conversations, still enjoying some food in limited quantities, and being in control of her own health care. However, not everyone has such a good plan B at the end of life, and that is why I strongly support the proposed amendments to the law that include Audrey's amendment, which would allow a waiver of final consent to MAID if the person was at risk of losing capacity before their MAID date, and removal of the reasonably foreseeable criterion without the inclusion of new safeguards. If Audrey's amendment had already been in place, there would have been less pressure to accelerate MAID for Marilyn. Motivated by my experience with Marilyn's death, I was one of the more than 300,000 Canadians who provided feedback in January on the potential changes to the federal assisted dying law. In the last 5 months, I have talked to many people about MAID and have not found anyone who said they are opposed or have serious reservations. Although I have not made any general announcement that Marilyn's death was medically assisted, I have voluntarily shared this fact with a lot of people I know, and others have asked me the question. You will see how one person reacted on a slide that will be shown shortly at the end of my presentation. In closing, I want to recap some of the key reasons why Marilyn's death was a good death. Firstly, Marilyn understood her situation and wishes, and we had discussed these subjects in advance. Secondly, the healthcare system and healthcare professionals involved during her final weeks were very supportive and responsive to her wishes, including for MAID. And her palliative care physician was a key ally. Thirdly, she accomplished her wish to not unnecessarily prolong her life and to die peacefully at home. Fourthly, in her case, she clearly qualified as having a grievous and irremediable medical condition, a key requirement for MAID. She had time for quality goodbyes with many family and friends. And finally, she was herself in the ways I have described right to the last minute of her life. Thank you to Dying with Dignity for allowing me to share my experience on this panel, and to all of you for listening.
Thank you, Maury. And thank you to all the panelists. And I think Maureen will be putting up that slide shortly. I'm not quite sure if we still have Maureen with us. Can you all hear me?
Yep.
Okay. There's the slide. Wonderful.
There we go.
Thanks, Maureen.
Sorry. Mhm.
And I think we'll be moving now to the Q&A. Once you've had a chance to read the Facebook post, we'll give you another minute or so. Thank you for sharing that Facebook post with us, Maury. And Maureen, would you do you want to moderate the questions now?
Sure, we'll move into the Q&A. The first question here, I'll start with one that was sent in earlier. I believe this would be a question for Louise. What is covered during an assessment for MAID, and how much is related to physical or medical conditions, and how much is psychosocial? And I think sort of the gist of this is around assessing suffering.
So from a suffering point of view, suffering is what the patient says. So suffering can be psychological and suffering can be physical. It's not my job as an assessor to decide if the suffering is enough. If a patient tells me that they have intolerable suffering, then that, as far as I'm concerned, is proof that they have intolerable suffering. Unless there was some other reason to doubt what they were saying, suffering is up to the patient to describe and define.
Great, thank you. I think that that answers that one. Here's another medical related question, Louise. After you've had the substance administered to cause death, how long does it take for someone to die?
Once the medications are started, it takes 5 to 10 minutes for the person to pass away. And it's during that time the medications are being given throughout that time. So it's not that there's an injection and then you wait 5 to 10 minutes. It's about 5 to 10 minutes of giving medication and the person then passes away.
Another question here, which is about, I guess, access to medical assistance in dying for somebody with Alzheimer's diagnosis. And I'm not sure if Daphne, you want to speak to this, and Louise, whoever feels most comfortable.
Well, I can just say that's the primary, I think, issue, and it's what everyone is concerned around about advance requests, about opening up MAID to those who want to make an advance request. And you know, I on my slide about advance requests, I said there's the different categories. There's before you've had any diagnosis, where you just say, if I ever got Alzheimer's, I would want to have MAID at a certain point in that trajectory of that disease. Or you get diagnosed with Alzheimer's, but you're in very early stages, and you say, now that I have it, you know, I want to be able to access MAID when I'm at a certain point in that trajectory. And I, you know, that is something that Canadians, when surveyed, the majority of Canadians support advance directives in those kinds of circumstances. But that's the question that the government is going to have to wrestle with. And I think the issue is what you do with people who have very clearly expressed wishes, but then when they get to a certain point in the disease, those wishes aren't what they're saying anymore. And do you go with what the original advance directive or advance request said, or do you go with what the person is saying to you now when they're in front of you? And I think those are the issues that are going to have to be worked out. And always, one of the things to always remember, and this I would ask Louise to weigh in, is, I mean, part of this, and this is something was very clear in these independent reviews, we have to take into account the comfort level and the expertise and the feelings of the providers, and how comfortable they're going to be in various circumstances depending on how much we open up MAID. And we have to be very aware of the people, the humans involved in carrying out MAID and making sure they feel supported and protected. So maybe Louise, you could speak to that issue.
Sure, thanks, Daphne. There's been a lot of discussion among providers about what do we do with somebody who makes an advance request, because it's not just a philosophical question to ask who is it that's making the decision. So if I make a decision now that some future self of mine, when I don't recognize my children, or I can't dress myself, or whatever criteria I have, if I say, if I get to that stage, please assist me to die, what happens if those aren't my thoughts when I reach that stage? Personally, my father had Alzheimer's and was on a locked ward at the end of his life, and I'd always grown up knowing if he was ever having Alzheimer's that was severe, he wanted to just, well, he'd say, take me to the backyard and shoot me. But he was the happiest I'd ever seen him when he was on that locked ward. He had friends, he enjoyed making cookies and things. So the man who was living on the locked Alzheimer's ward was a very happy man. He was no longer my father, but he was happy. And I would have a lot of difficulty honoring an advance request for a person who was happy when I walked in. And so I'm not sure how I would be able to cope with honoring an advance directive, especially when it wasn't me who had talked with the person years ago to see how they felt about it. And I've talked with other providers, and most of us have similar issues around this.
Great. Thank you both for your answers. Just looking for the next question here. And we've had a number of them come in. I think a lot of them have been around advance directives for dementia and Alzheimer's. Okay, that's regarding intolerable suffering. Sorry to take a while, but there's a big volume of questions. The next one I have here is, how does Canada compare to the leading countries in the world on this issue? So somebody with a sort of more global look at provision of MAID. What can we learn from them to improve our legislation?
Well, there's quite a few jurisdictions in the world that do allow MAID, and there are more joining that family all the time. And I must say, there's very different regimes for organizing it, depending on where you are. And commonalities, I think, are that most jurisdictions do require a grievous and irremediable condition. So MAID is not available unless you have reached this point of intolerable suffering and you have a diagnosis. Most jurisdictions do not allow people with a mental illness as their only underlying condition to have MAID. And some are more restrictive than us. There are jurisdictions in some new legislation in Australia, for example, where providers aren't allowed to bring up MAID as an option. They have to wait until the person themselves asks about it. So they're not allowed to, put it forward as one of the many ways in which you could deal with your intolerable suffering. So there's a huge variety, and we are working with other jurisdictions all the time. So the Carter decision that the Supreme Court of Canada issued was based on a trial record which included all kinds of international comparisons and best practices from other countries that showed, for example, that there's no slippery slope. It's not like because you legalize MAID that suddenly you have people dying when they really don't want to be dying. So we have learned a lot, and we are continuing to work with other jurisdictions, but we're also now, I think, a model to those who are coming after us.
Great, thank you. Another question about the constitutionality of I'll read the question directly. Is it constitutional to require people whose death is not reasonably foreseeable to go through a longer process, given that the Canadian Charter of Rights and Freedoms states every individual is equal before and under the law and has the right to the equal protection and equal benefit of the law without discrimination, based on the categories described in the Charter?
So one of the great things about governments when they pass legislation is they give lawyers and constitutional scholars tons of work after every piece of legislation is passed. I am quite certain we will now see a challenge to whatever legislation comes out of Bill C7. And if there is that longer reflection period, you could well see a constitutional challenge that it is, it's unconstitutional. The thing about the Constitution, though, is that the Charter of Rights and Freedoms has this section 1, which allows the government to override individual rights for essentially for the greater good or for greater policy objectives. And I think, so the reasonably foreseeable, natural death reasonably foreseeable as a criterion was something that was constitutionally challenged, and those challengers won. Whether a challenge around the waiting period would be successful, I think would depend a lot on the evidence of the harm that comes from the waiting period. And because there is a possibility of avoiding it if you're having a loss of capacity that is imminent, it might be that they don't consider that to be, that the 90 days isn't so much of a harm when your death isn't reasonably foreseeable. You're not imminently facing the loss of capacity. But that'll be the great thing about this, is that it will generate lots of work for people like me who want to think about these things, and I don't know what will happen.
Great. Thank you. Here's a question about access to MAID, and can that take place in a hospice or must it be in a home? And also, I guess adding a hospital to that, that if Louise, if you want to answer that, I think.
Sure. So,
Can you hear
can
me
you hear me now?
Yep, you're still good. Yep.
So if
So it's
MAID,
I'm going to mute your phone. I think your computer is working fine. Go ahead.
okay. So if MAID, I can't do this, it's duplicated.
Okay, I will change that. I will unmute your other, there.
So if
Can you
MAID
go
is available, yeah, can you hear me?
Yes.
Great. So MAID is provided in hospitals, and it's provided in homes and retirement homes and long-term care facilities. Some hospices will allow MAID on site. Initially, it was not allowed in the majority, but over time, more hospices are allowing it. But I'm not aware of any hospice that would allow a person to be admitted for the purpose of MAID. So if somebody needs admission to the hospice for control of symptoms, and while they're in there, they end up deciding that they want an assisted death, then there are certainly hospices who are now allowing that.
Okay. Thank you, Louise. We've had another couple of questions about organ donation with people choosing MAID. Is there a protocol right now? Are there considerations people should be making, advanced documentation? Any comments on those?
So yes, you can have organ donation as a result of a medical assistance in dying. And so if it looks like a person could be a candidate to donate organs, then in Ontario, at least, the Trillium Society is called, and specially trained people discuss the option of organ transplant. Generally, organ transplant means that you would have to have your MAID provision in hospital, but I'm now aware of 2 cases in Ontario where someone was able to have a MAID provision at home and still be an organ donor, but it took a lot of coordination to make sure that they could get them transported to the hospital quickly enough and that sort of thing. But yes, organ donation is definitely a possibility in somebody who would be eligible to donate.
Mm-hmm. Thank you. When Maury was talking, he described his wife's situation in Ottawa, and I'm wondering, and maybe Susan, you can comment on this, is that an anomaly where there's a supportable, very supportive access, or is that, you know, generally true across Canada, or access to MAID?
As a general rule, and Louise might also have comments on this, I would say that certainly our witnesses are very responsive, and we've been fortunate to have the Ottawa Hospital take a very strong position to ensure providing access to MAID in the hospital in Ottawa and the Queensway Carleton. And then we've been very fortunate in the community to have physicians like Louise who are willing to help provide MAID in the home or in a senior's residence if it's requested there. My impression is that MAID is more readily available in larger urban centers in Canada. So rural, more remote communities, I believe it's more of a struggle for people to access MAID, and there may only be 1 or 2, you know, if they're fortunate, physicians in the community who may be willing to provide. But there can also be some concerns in those communities about stigmatization of physicians who may choose to provide MAID and the impact of that. So I don't know, Louise, if you've got any other knowledge or comments you'd like to add?
No, I think people try really hard to make it happen when it's possible. I think people who go into medical assistance in dying are really committed to patients and will do what they can to make it happen.
Okay, thank you. we heard a story last week of someone who had a MAID provision in a funeral home, and just wondering amongst the panelists if you have heard of these facilities being used before, and is this, how frequently is this done? It's something relatively new to come up.
So yes, I'm aware of it happening. I'm aware of it happening in BC, and I'm aware of a recent case in Ontario. And what happens is basically your choices to have this done is either the hospital, your home, the long-term care facility, or the hospice. And if for some reason none of those are available to you, and recently it was, you couldn't transfer a patient in because of COVID, and I'm not sure why it couldn't be done where the person was, but you need a place. And it can't be done, for example, in a hotel or a public place. And if you don't have a friend who's willing to let you die in their home, then it's very limited where this can happen. And funeral homes are a place that it's a private business. They can give permission to have this occur on their premises. And from what I've heard for people who have ended up having it done in a funeral home, it's been a good solution for them. It has never been done in Ottawa.
Thank you. We're getting close to the end of our allotted time. If people have questions that they want to ask, we have time for a couple more, and you can type that in on the Q&A screen. So please, please feel free to give us a question. If I want to access MAID, but my family, my loved ones are against it for religious reasons, what can I do? I think this must be a situation that comes up where somebody's partner might not be aligned with their decision to access MAID, and how public is that decision need to be? Is there a need to inform the family? How does that work?
Daphne, do you want that one, or I can take it? It doesn't matter.
Well, legally speaking, the choice rests with the person making the request and who is assessed as eligible. So, you know, legally speaking, as long as you have capacity to make that decision, you meet the criteria, there is no one who could stop you from doing it. But as far as I know you would have so much more experience, Louise. I mean, I know these conversations are difficult, so maybe you can speak to that. Yeah.
Sure. So ultimately, we can go ahead and provide MAID for a patient who has capacity and meets the legal requirements. But in reality, it would be very difficult to do this if it was done in secret, or if it was done against the family's wishes. And so we do everything possible to encourage conversation before. And I have never ended up in the end having a person decide to carry on without letting family know. And I have seen that patients have been able to resolve family conflict as a result of the request for MAID. So I strongly encourage that this is something that's discussed with those who are closest.
All right.
I'd like to comment on that too, if I may, from 2 points of view. I mentioned the conversation we had with Marilyn's sister and brother-in-law about 10 days before, or I forget exactly when it was, before the procedure. We had that conversation partly because they were among the people I wasn't sure would be very good with the idea, particularly her brother-in-law, but in the end they were both there for the procedure and very supportive. The other aspect in Marilyn's case was she specifically asked me to let our son, from whom we have been estranged for quite a while, to let him know that this is what she was planning. He didn't respond, but I did I did honor that wish of hers. So he also was aware of what was happening.
Thank you. I see that we are at our time limit here. I want to thank everybody for their contributions, and Maury, thank you for sharing your personal story. Susan, did you have any closing comments you'd like to share with everybody? Or
only to say that we really appreciate that all of you chose to participate in this session, the panelists and the participants, and thank Maureen for stick handling all of the technology for us. And, you know, thanks to all of you who continue to support Dying with Dignity Canada and our mission to try and make assisted dying accessible to Canadians who need it and who are suffering. And I'd encourage you, if you found this panel discussion interesting and informative, and there are other topics related to end of life that you may have an interest in, that perhaps you get in touch with the national office and let Maureen or one of the other staff know. And I'm sure other similar webinars can be arranged as they have in the past. There was one recently about ensuring you had some type of discussion with family members in this pandemic situation, and that you had something like an advance directive or an advance request related to that. So thank you all again, and until the next time.
all right, thank you all very much.
Thank you.
Bye-bye.